12 o'clock. Everyone is welcome to this exciting session.
I think there's a problem. Rihanna has left.
I think there are internet issues, connection issues.
Yeah. Just give it a couple of minutes.
Thank you for joining. I'm Dr. Atiq. I joined from Orlando, Florida. I'm a gastroenterologist, and I'm one of the founder director of Planetary Health Academia. And we have doing a lot of this kind of sessions in Bangladesh to helping the global community to disseminate the information to healthcare and technology. And I see Professor Fatima Ashraf is here, who's a renowned gynecologist. I know her for a long time. I know her when I was in medical school. I see Professor Shamina Chaudhary is also here. And I really wanted to thank Professor Hossein and Dr. Shiva to join us. Thank you. I'm a gastroenterologist, but I really am curious to know about today's meeting. So I hope Dr. Rihanna will come back quickly, and we can start the session quickly.
Thank you, Dr. Atiq. We are very much honored to have you because you are contributing so much for the development of the medical education in our country. Thank you very much from the core of our hearts and on behalf of our students. So I think maybe we should introduce ourselves. So let me introduce myself. I'm Professor Dr. Fawzia Hossein. I'm currently working as Unit Head of Department of Gynecological Oncology, Bangabandhu Sheikh Mujib Medical University. And I was the International Affairs Secretary in the previous OGSP. And now I'm the Vice President of Bangladesh Society for Colposcopy and Cervical Pathology. And I'm honored that Rihanna has invited me to be a panel member in this very important discussion of the surgical checklist of WHO. I think Dr. Siva and Dr. Rihanna, they are going to be the speakers, and myself being one of the panel members, and Professor Fatima Ashraf, who is currently the Secretary of Research in the current OGSP, the Obstetrical and Gynecological Society of Bangladesh. She's a renowned obstetrician and gynecologist with a special interest in research. So I would request Appa to introduce herself, to say a few words on this.
Thank you for introducing me. Actually, here are our senior professors, Professor Kohinoor Madam, Professor Shamina Chaudhary Madam, and others. Almost I'm introduced by Fawzia. Actually, I'm the former head of OBGYN department in Shohid Sarwardey Medical College Hospital, and I'm the co-chair in Skill Development Department of BCPS. And you already know that in the recent committee of OGSB, I am joined as research secretary, and also the former chairperson of Public Health Foundation of Bangladesh. I'm really grateful to be here in this great platform. And I think the topic is very important for all of us, really. Thank you so much, and hope we'll enjoy the presentations and sessions. Our madam is here.
Professor Kohinoor Begum Madam, who is our past president of OGSB. Madam, welcome, and we are honored to have you in this platform. And previously, we have introduced Shamina Chaudhary Madam, who is also the past president of OGSP. We also have Professor She's also professor of obstetrics and gynecology and past scientific secretary of OGSP. I can see her. Rihanna, do you want to?
Yeah, sorry for the
viewers. So we have been introducing ourselves.
Yeah, thank you.
Dr. Siva is left. Okay. So if you introduce Dr. Siva, and then we can go to our presentation. You can go to your presentations. Dr. Siva,
Okay.
please introduce.
Hi, I'm Siva Kumar Balasubramanian, one of the anesthetic consultants who work with Rihanna at Nobles Hospital in Isle of Man. I have special interest in obstetrics and intensive care medicine. Thank you so much for inviting for this webinar. Thank you, Rihanna, for inviting me as well. So the idea is to discuss about WHO checklist and surgical safety checklist. And then Rihanna asked me to talk something about how to make the anesthesia safer. So I've included a little bit before going into WHO checklist about some important preoperative assessment bit, not in an extensive way, just to give you an outlook, very little outlook about this. And then we'll start with that, and then we'll go into WHO checklist. Thank you.
Thank you, everyone. Sorry, there was some technical hitch. So when I started, then I couldn't continue. And actually, I'm grateful that Fauzi Appa took over. I can see also Zinat Appa is there. Zinat Appa, do you want to introduce yourself?
Well, thank you very much, Rihanna. I am just looking forward, interested to see and enjoy the webinar. Thank you.
Okay. So the plan for the program today that I'm going to talk about the surgical safety and the WHO checklist. And then my colleague Siva is going to talk about, as we discussed, there's some pre-assessment, not in details, but importance related to the surgical safety. And then we're going to go to our two learned panelists for their inputs and discussions, and their and then we're going to give some time to the audience to see whether they have got any questions. I also got a case which I'm going to sort of request the participants to tell us what they have learned and what they can apply for that case, what we're going to discuss today. So without wasting time, I think we're going to start there, but I can see Kohinoor Madam. Assalamu alaikum, Kohinoor Madam. Ji, Madam. I'm so glad that you all are here. I can also see Atik Bhai. I think Atik Bhai is very busy. They're all 12 o'clock on Friday. Thank you, Atik Bhai, for joining us as well. And thank you all the participants. I really hope you're going to achieve something out of this session, and then jointly we can discuss how can we move forward applying this WHO checklist or surgical safety in Bangladesh. So I'm just going to share my screen. Thank you very much. So the topic today is surgical safety and WHO checklist. I am Dr. Rihanna Zaman. I'm the consultant obstetrician gynecologist. I'm the clinical lead for Obs and Gynae in Nobles Hospital, Isle of Man. I also lead the PHA Obs Gynae faculty. Thank you for joining us again. So it's actually, as you look at that, WHO has told us, or this WHO evidence there, that 20% of the inpatient operations get complicated. The crude mortality rate from major surgery is 0.5 to about 5%. And half of this, all the adverse events are related to surgical complication in hospital patients. But the most important thing is that half of these cases are preventable. Surgical safety principles needs to be constantly applied, even though this WHO checklist has been here since launched in 2009, but still it's not being applied consistently, even in the high income countries. So it is need to be looked at. And if we actually apply it in our daily practice, especially in the surgical specialties, then we can actually save quite a significant amount of lives. And now, if you look at the history of the WHO checklist, in 2002, the World Health Assembly noticed that there was significant amount of complication related to the surgery or hospital admission. So that time, they actually requested WHO to make a patient safety as an important issue. And then there was a global patient safety challenge campaign started. In 2005, then there was the loss of hospital-acquired infections. So then WHO started the campaign of clean care in safer care, followed by Safe Surgery Saves Lives, which was in 2008. And then WHO guidelines for safe surgery was launched in 2009. There was 10 essential objectives of safe surgery, and the checklist, WHO surgical safety checklist, was derived from that guideline. Now, what are the 10 WHO essential safety guidelines and what are their objectives? Number one is it should be the correct patient, and we should do the surgery on the correct site, because many of the time it happened that the patient underwent the wrong sided surgery. There was also, the objectives was to have safer administration of anesthetic agent. So while protecting the patient from the pain, but at the same time, we like to have the anesthetic agent as a safe administration. Safer airway and respiratory function, prevent blood loss, avoid any allergic or adverse drug reaction. Other 5 were minimize risk of surgical site infection, prevent inadvertent retention of sponges or instruments within the surgical cavity. And once the end of the surgery, if it's removing any specimen or sending to the lab, that should be securely placed in the container and accurately identified. It's also very important that the efficient communication between the team, the surgeon, the anesthetics, the scrub nurses, even the trainees who are participating on trying to be learned in the teaching hospital. That's very important that we all communicate well. An efficient public health system where all the data will be collected so we can learn from the mistakes. So WHO checklist is WHO tried to make it very simple and efficient tool to check the safeties. The tool actually helps to improve the effective teamwork and communication, encourages active consideration of the patient's safety, ensures consistency in patient safety in surgery, introduces and maintains a culture that values patient safety. So if we can actually use this tool or checklist consistently every day in our operating theaters or surgical fields, then we can actually continue the culture which will be valuable for patient safety. Now, this is the WHO surgical safety checklist. And if you look at it, there is actually 3 parts. One is sign in, time out, and sign out. And it has got also 3 phases. One is sign in is before the induction of anesthesia. And the time out is before even we start the skin incision. And then sign out is when we finish the surgery and patient is going to go to recovery or post-operative ward. So then we can make a plan. So by the time we'll know that how the surgery went and what are the things we need to do to look after that patient. Now I'm going to go in little details about this 3 component of the checklist. Now the sign in is normally done by the anesthetic team, by the anesthetist and the assistant, or the ODP, we call this. The purpose of the sign is to ensure that it is safe to induce the anesthesia and that all preoperative checks has been made, all the preparation has been made for the surgery. And it must be completed in the anesthetic room prior to the induction of the anesthesia. All the questions which are in the checklist need to be read out loud, and then we all confirm, the surgeon, the anesthetic team, and the nursing team, they all signs that and agrees. The signing means they're agreeing. It is often feasible to include the patient in the sign-in if they're having like spinal anesthesia, and that should be encouraged. It is the element in the checklist that needs clarifying, that whether they have got valid group and safe sample, and that must be done at the time and the sign-in repeated from the beginning. we should always stop before we start the surgery or put the anesthetist if we are not agreeing in anywhere, if there is no agreement between the surgical team, anesthetist team, or the nursing team. Anesthesia must not commence until any discrepancies has been resolved. No other activity should be happening while the signing is being happening. So that's the first phase. And the second phase is, it's called timeout. It should be completed after the patient has been safely positioned and appropriate monitoring has been attached. All activity must stop to allow the staff to focus on the timeout. The purpose of the timeout to ensure that the correct procedure is undertaken on the correct patient and the correct measures are in place to prevent any patient harm or complication. And that must be completed by the whole team. That means the whole team needs to be present when we're doing the timeout. Timeout should be completed after the patient has been so safely positioned and appropriate monitoring is attached. And as I say, timeout is usually completed once the patient is prepped and draped. However, in some specialties, it may be appropriate to do the timeout before draping. It is essential that the timeout is done prior to incision. So that's the second phase. And then we come to the sign out when patient is already had the surgery done and we just need to make a plan how we're going to look after her after the surgery in the post-operative ward. And it should be completed when the patient has had the surgery done. We should make whether the procedure we planned, whether we managed to do it, whether lines has been flushed, whether any post-operative plan, we all agree, any specific concern, whether if someone had quite a significant blood loss, whether we need to give her blood transfusion, when they need to have the repeat bloods. Here in developing ward, that one of the biggest complication is venous thromboembolism. So we always have to have a plan how we're going to prevent it happening, whether they need state stocking, whether they need any Clexane or heparin, and whether the surgery is a big surgery that they need to be inpatient or it's going to be day case, whether they're going to discharge on the same day with a plan. Now, in NHS England, we also follow another 2 extra steps. One is briefing and another is debriefing. So the briefing is normally at the starting of a list. So if you're doing a whole day list, we talk about, we introduce ourselves, the whole team. We then go through the list, and everyone, when they're introducing themselves, they actually state what is their role. And even if, say, there is a newer member there, some medical students or midwife student or nursing students, they should be also encouraged to be included in that briefing. Then we do the overview of the list, that how many patients are there, what are the surgery we're planning to do. All the patient must be discussed. It is essential that each patient is referred by their name, and the operating list describes the correct procedure, the site and site. It is also essential that we then plan, if it is going to be a whole day surgery, it's a long list, how the staffs are going to take their breaks, when they're going to, who is going to operate when. So basically planning the whole list. Then we confirm the order of the list, which patient is going to go when. Sometimes when we look at the list, looking at their comorbidities, we plan the list as well. If someone, say, got diabetic lady, then we try to put them in the first. Or if there is, say, we got some mixture of cases, like we got some day case or inpatient cases, we try to do the day cases earlier in the day, so then they can go home in the later on in the same day. So then we confirm the order, then we check the understanding that whether everyone in the team are in a agreement, or check we do understood what we're going to do. So basically here we're trying to be encouraging, in spite of hierarchy, any junior or any senior member can actually agree or disagree, but at the end of the day, we should have a clear communication and understanding. So that's the briefing. The same thing we do here after the third, the sign out is called debriefing. Debriefing is take the opportunity to see whether how was the performance, what are the positive achievements, whether there is any complication, whether there is any issue with the instruments, whether we need to report the instrument or anything else needed to be done, whether there was any areas where we need to make some improvement. We also acknowledge all the good performances. We thank everyone. We boost, that helps to boost the team morale. And we try to do it, or should be doing it, in a very professional manner. And everyone in the team should be encouraged to contribute and respected. Now, there are some challenges when we WHO tried to, or this checklist was implemented, or sort of trying to be implemented in low-income settings. There was maybe some of the hospital already had duplicate existing checklists, so it was difficult for them to duplicate. So that caused, we call this checklist fatigue or irritation. Some of the team thought it's time consuming, is inconvenient. Maybe it's taking a little bit more time. They should go at, just start the surgery. So that was one of the problem. Poor communication, unfamiliarity with the structure of this checklist, confusion, and who should take the lead, who should prompt the items, absence of key team members, since the surgeons were not interested, or something, it was not, the nursing team was not interested, and some people thought, oh, actually it's just a tick box exercise, so we shouldn't do that. Some of the study says, or some of the countries, they came up with this saying that, oh, we have not got enough resources, like say marker pens to mark the site of the surgery, or we don't have antibiotics cover, we don't have pulse oximeter. So these are the pragmatic challenges. There were some attitude challenges, there's some resources challenges, and these are the problems they faced. Now, what WHO is trying to do, they are trying to say that the evidence that since the introduction of this checklist, how much improvement has been made. So the rate of death was 1.5 before checklist was introduced, and then it's declined to 0.8%. And this was a study, and it was published in a journal, reputed journal. The link is there. And the study was called Surgical Safety Checklist to Reduce Morbidity and Mortality in Global Population. Even in lower income countries, wherever it was introduced, the rate of death decreased by 50%, which is quite a lot. And post-operative complication rate decreased by 36%. So it's quite dramatic. And I think that's quite encouraging that other low-income countries should actually introduce that as well. It also other advantage, that checklist help the surgical team members to communicate with one another in that way that improve the patient safety. Team communication was creating adherence to patient safety practices, and the checklist programs improve the safety of surgical patients in diverse clinical and economics environments. There's another study which published in the London International Journal of Surgery, and how the surgical safety list checked is helped in the developing country. I'm not going to go in the details, but the link is there, and it is there, so someone interested can actually have a look, please. In the WHO website, there is details about the tools, how to implement this tool. There is even some video instruction, which will help people if you want to introduce this to any of your hospital, that will be very important tool to look at. It will be very useful. there is also in even the same WHO website, depending on your facility, what is available in your hospital, it can be also modified. So there is a chance of to use a modified checklist, and the link is there as well. Now we're talking about utilizing this checklist for surgical field, but actually some of the field that, like say in medicine, like say in central venous catheterization, in pleural, it is called pleural checklist, when the insertion of just chest drain. Even there is a checklist made for prevention of venous thromboembolism. So it's not only that surgery has been sort of benefited from this checklist, even it has been like trying in a modified way in the medical field as well. So at the end of the thought, what I'll do, I'll just leave this case and we will discuss this case after we hear from Siva. Is it okay? Thank you, everyone. Thank you for listening.
Thank you, Zama. Right, are you happy for me to start?
Yes, please. Thank you.
Right, I'll share my presentation. Can you all see the presentation?
Yes,
Perfect.
yes.
Right. So what we'd like to do is a simple summary of how we can achieve a safer pathway to anesthesia. Historically, I would say the flying and anesthesia has been linked together. And initially, it's the anesthesia specialist, the specialist, they took it very well. Now it's actually been followed by whole of healthcare system. It's very easy to compare the anesthesia with aviation, significant similarities. For example, the takeoff, cruising, and landing, we compare that to induction, maintenance, and emergency. You may all have seen that if there is an operation running for about 4 or 5 hours, the first half an hour, the anesthetists are busy, and then once the patient's on the table, you start operating, no one hears anything from the anesthetics. A lot of people think we are doing some Sudoku or reading papers or something else. But that's a good thing. But all of a sudden something happens, we all get busy and a bit of tension there. So it's something like you have turbulence and the flight's running very smooth. And then the turbulence settles, and then we just go back and settle. And the landing is compared to emergency, which is also very important. I would say recovery of the patient, that is emergence of the patient, is a lot more high risk than induction. There are plenty of evidence to say that there are more airway accidents during recovery of the patient than during induction. So how do we do this 3 phases very safe? Okay, eternal vigilance at all stages is the most important part of anesthesia or safe anesthesia. What I would always say is I want my anesthetic to be boring. I don't want any excitements. If it's boring for me, it's safe for the patient. That's what I always say. Right. When we say safe takeoff, how are we going to prepare for a safe induction or safe commencement of anesthesia is how we actually prepare the patient for the perioperative period. The AAGBA safety guideline for preoperative assessment and patient preparation, it's got a good guidance. It's freely available for everyone to go through, and it gives you a really structured guidelines about how we can assess and prepare the patient. I always consider when people say, oh, Siva, can you please check this patient is fit for anesthetic? I say, no, 99.99% of the patients are fit for anesthesia. When we don't do anything, we just get them off to sleep, wake them up. They will manage. What makes it difficult is the surgical stress response. the patient's stress, physical and hormonal and biochemical stress due to surgery and post-operative period is what makes the surgery unsafe. Or so what we need to see is, are they fit for the perioperative period? Can they withstand the surgical stress response? It's always multidisciplinary. It starts from the first time when the patient sees the physician for any illness which they require surgery. The surgeon assesses their fitness for surgery, and we need to actually optimize the patient. What can we make better for the patient so they can actually withstand the insult of the whole procedure? I'm a pre-assessment lead. We do pre-assessment clinic every week. It's run by 3 anesthetic consultants and 4 or 5 pre-assessment nurses. The nurses see about 5,000 patients in a year, and then we pick up 10% of them. So the nurses see them and they filter the patients. Most of them, they can assess them and then they can get them through. Those patients who are high risk, or if they are not comfortable, if they need some referral to any of the specialties such as cardiology, respiratory, other things, or if they need any advanced investigation, we get to see them. And then we organize the investigation, we communicate to the different specialties. And what is most important is the communication and documentation. So when we do that, the patients go through the pre-assessment process very smooth. So by the time they actually come to the operating theater, they are as much as possible optimized for the surgery. We may not be able to optimize them 100%, but that doesn't mean they can't have the operation. We try to make it as safe as possible through the pre-assessment procedure. The second thing I want to actually mention about this, there is an increasing incidence of obesity across the world. I would say our part of the world is actually increasing. So obesity anesthesia is a big topic, and it comes with a lot of significant anesthetic complications. I would request you, very simple again, SOBA UK, it's a Society of Bariatric Anesthesia UK. You can all go in there and you can actually access the guidelines. They have guidances for anesthetic management of obesity in adults, also in children. They have a 1-page chart of how to preoperatively evaluate the obese patients, intraoperative management, and postoperative management. I just split into 2 so that you can see how they are, how these guidelines can help. They're pretty straightforward, very simple. If we just follow this, we will be very well managing these obesity patients, and we can actually make it as safe as possible. One thing I would want you to see in this is the red box and the arrow says ramping, how positioning of obese patients during induction and also during the surgery is so important. Rihanna will know and understand, and most of your obstetricians, gynecologists will understand, because most of the gynecology procedures are done head-down procedure, and you may have experienced the. Can you hear me?
Yeah, we do.
Good. I thought I lost you. So most of us then you ask for head-down procedures, head-down position, and the anesthetists are not very happy. That's because positioning these patients head-down has massive cardiovascular, respiratory compromises. So that's why we have to be careful. So there's a balance between how what position you need and how safe it is for this patient. What I want to emphasize is obesity itself is a disease. What I always say, if the patient is morbidly obese, they are ASA3. ASA3 is American Society of Anesthesia. They've got different grading system. ASA1 is fit and healthy. ASA5 is patient's dead. ASA3 is severe systemic illness, which actually compromises the patient's normal lifestyle. I would say morbid obesity is stage 3 straight away. Patients coming for any surgery, elective or emergency surgery, let's say elective surgery, they are morbidly obese and they have no other documented or reported health problems, we should consider them as AS3 because they may have undiagnosed hypertension, endocrinological problems, and they may have sleep apnea, which puts them at higher risk of pulmonary hypertension. We may have real difficulty in monitoring their blood pressure. And as I said, positioning, they are at higher risk of deep vein thrombosis, postoperative pulmonary embolism. All these things has to be thought before the patient even gets to the theater. Sometimes we have to tell the patient the real fact, how risky the surgery is. Then they may actually opt for non-surgical options if there are any non-surgical options. I'm just going to stop there about the pre-assessment. I'm just going to just link that with the WHO checklist, how anesthetically we can approach the WHO checklist. Rihanna covered it in a very detailed way. I'll just touch base this. The Safe Surgery Saves Life campaign started in 2007. That's when, after that, the Safe Surgery checklist in 2008 was piloted across the world in different countries with 8,000 patients. And what they found out is the complications and the death rate has significantly dropped, which is statistically significant. As I mentioned earlier, it came from aviation checklist. So basically, we cannot remember everything, especially in emergency situation. So what we have in our anesthetic room, we have a small booklet containing all the emergency situations, such as cardiac arrest, arrhythmias, malignant hyperpyrexia. If I can explain, malignant hyperpyrexia is a life-threatening anesthetic complication, difficult airway, not able to intubate, ventilate, and anaphylaxis. All these acute life-threatening emergencies, we just made a page of checklist. So someone reads it from the corner of the operating theater, making sure we've done everything. It is very useful in the emergency situation. You might not remember everything, and this is very useful. I would recommend, if you haven't got this already, please give it a go. Why we follow WHO checklist? If you try this, you will realize it's pretty simple, straightforward, and it's very easily applicable. And you can actually measure how emotionally and patient safety-wise it works. The objective is its safety review. As Rihanna mentioned, it's a last opportunity for the patient to have a safe surgery before the patient is going under anesthetics. During the team brief, we go through individually about patients, whether they are optimized, if they have any comorbidities, if they have any risk, how we can actually safely anesthetize them, both intraoperative and postoperatively. We talk to each other. Every member of the team have the opportunity to share their opinion, and we prepare for any eventualities. We just have plan A, plan B, plan C, considering, say, if the patient has got airway difficulty, what are we going to do? If they bleed unexpectedly, what do we do? And it gives an opportunity for everyone to speak up. And there's no need to be shy, because even today it happens when you are a junior doctor, you don't feel comfortable talking to your senior about something they want to raise. But in the meeting of team brief, it gives them an opportunity to talk. The last thing about is the human factor, which is again coming from aviation. I don't know how many of you may have read this. There was a patient called Elaine Bromley. She was a 32-year-old lady who came for elective surgery. She was absolutely fit and healthy, and she died during induction of anesthesia due to difficulty in intubating. She had acute hypoxic brain damage. She died, she died after 13 days in intensive care unit. Her husband, called Martin Bromley, he was a pilot at that time. He took it on board. He's actually formed a group called Clinical Human Factor Group, And he's been actually going across the country, in fact, across the world, emphasizing the importance of human factors in safe anesthesia and safe surgery. Human factors become a big part of healthcare system now. That's why I mentioned about the team brief. So we discuss about allergies, blood loss, plan A to Z, whatever possible. And any constructive challenges, any mitigation plans, we discuss. Rihanna mentioned this before, so I won't repeat it. From the anesthetic perspective, before induction, sign in, that's again gives an opportunity for the patient, if they have understood the anesthesia and the risks and benefits of anesthetics, if they want to change the anesthetic choice, if possible, they can actually discuss that with us. And before knife to skin, timeout, again, all the other things which we may have missed during the induction or during the team brief, it gives an opportunity to discuss any further. After surgery, sign out, we just check all the safety checks like swabs and counts, any post-operative plan for the patient, any high-risk patients, where they are going, if they need a high dependency care, how long they have to stay in recovery, how frequently we're going to monitor them, any blood test to be taken afterwards, all those things can be discussed. Individual patients at the end of the surgery. And then comes debrief, which happens at the end of the list when we finished all the cases. It happens. Debrief is my favorite part of WHO checklist, because we may have a fantastic day or we may not have an absolutely fantastic day. So it's an opportunity for us to learn from our good work and not so good work. So we appreciate the team, how well, efficiently they work, and celebrate your teamwork and identify any opportunities to improve. You may not have had anything to improve that day. Then we'll say, well done, everyone, and we all go home happily. So that's how it works. It gives the team a happy day to go home to. And we'll also discuss the environment, not just clinically, how the team interacted between each other, how's the relationship between the team that day. So all these things can be discussed at the debrief. If you don't have it, as Rihanna said, you may have something of this kind in your hospital. If it works fine, it's absolutely good, but it's worth comparing if you have anything missing compared to WHO checklist. And the culture of introducing something new may not be perfect, and it's not just there or here, it's everywhere. I've seen it. You suggest something new, there's always someone say, oh, we don't want to do this. So the culture is there. Tackling the culture of change is always difficult. And the engagement of the team is very important. Not everyone engages with changes, and support from the management. As clinicians, we can come up with amazing ideas, but we need support from the management so that we can actually implement this without any problems. How do we successfully get this change? First, we deploy the change, and we support the change, and we seek for the support from your managers or seniors, and we can evaluate how the challenge is actually changing the practice, and we adhere to the changes. And to be honest, the WHO checklist doesn't need much resource at all. It takes 5 minutes every stages of this WHO checklist, and a printed paper. That's all it needs. There's not huge resource required for this. That's me. Thank you very much. And if you have any questions, please feel free.
Siva, we got one question. I think we got few questions in the chat box.
Of course.
I can see.
Happy to take any
But
questions.
I just request my respected panelists to tell us that shall we discuss the questions first, Fauzi Appa and Fatima Ashraf Appa? How do we proceed?
Maybe we should go for the questions from the audience and the quiz at the end.
Have you got any question, any of the panelists, or any, do you want to add anything? I think that's I like to know. So I come to Fatima Ashraf first. Have you got anything to add on what we discussed now, please, from my presentation or, Siva's presentation?
Okay, thank you, Rehana. Actually, both the presentations were excellent and so much resourceful. Actually, though it may seems that the SAFE checklist is a simpler one, but I think that from your presentations, it gives some deep insights. Why should we use SAFE checklist, surgical safety checklist, and its outcomes, that is immense outcome it actually give to us in respect to the safety, surgical safety of the patients. And if we think about our goals, our targets, even if we want to achieve the SDG or the universal health coverage, we must save our patients with quality service. So there is actually, I think that there is actually no way to omit the surgical checklist in our everyday surgical practice to have a positive outcome. And we all admit that actually, if we don't go through this process, there is so many risk or threat for death, disability, cost, everything. And as already said by Siva, that the patient who was Ellen Bromley, who actually not only one case, in all our settings, surgical setting, we know, we are very much acquainted with these sorts of problems in everyday life. So that the challenge is that how can we implement properly in our setup? That is actually real problem. And I think that the problem is much more in low income countries, because evidence, as you suggested from the statistics, that the risk is around 50%. Whether in developed countries it is low, because most probably they are making it as a routine for everyday life. But in our setup, we actually lacking this safety checklist application. I have some experience from our own hospital where I was working. Should I explain? Should I share that which we started in our hospital, or we say later on?
Please do. It will be interesting to know.
Okay, thank you. Actually, I was working in a tertiary level public hospital at the capital of Bangladesh. And you know, the quality service is always questionable in our setting. So there might be the quantity of healthcare delivery is much more, but the quality is in question. So in under the Health Economic Unit, a quality improvement secretariat was developed since 2015, and as a pilot project in my hospital, that is Shoisarode Medical College Hospital, we started quality improvement activities, and use of safe surgical checklist is one of the tool that we use with some small projects like PDCA, that is plan, do, check, and action. So actually, we introduced this safe surgical WHO safe surgical checklist in surgery and also in gynae. In our hospital, there are 43 quality improvement committee, and that was a team. That those teams were headed by nurses. So in the team, there were nurses, there were MLSs, cleaner like this. And there were quality improvement committee headed by the head of the departments of different disciplines. So once we initiated, actually we come to know, because everything it needs a lot of monitoring and governance. So when we was looking at how it is working, almost each day we found that it is not working properly. The first part, it was done by nurses, but in the second part, it it was mostly by anesthesiologists and surgeons. So yes, nurses cannot communicate with the surgeons or anesthetists properly. So as you know that, and especially you mentioned in your presentation that the teamwork is very important. So I feel that there was gap in teamwork. And what we found that at the end of the operation, commonly nurses give the hard copy to the surgeons that do it. So by this way, they usually try to, report it in the monthly report that yes, it is doing. Even then, it was no more than 35%. They actually completed the safe surgery checklist, and it was not on time truly. So I think that it needs a huge communication between the team, and it is a real challenge how we can make it as a streamline in our daily routine practice. Thank you.
Thank you, Appa. Thank you, Appa. At least you share your experience, and you can actually restart it by working on it, because as you shared, maybe the teamwork was not great. Maybe you need to go back to revisit the areas you think there were some weaknesses and then try to relaunch again. To be honest, myself and Siva was talking about it. We will be very happy to help you to relaunch any hospital you want to help you to modify it according to your facilities. And as we are also planning to come sometimes in February, so if someone wants to have hands-on help from us, we'll be very happy to do that. Now, I'd like to thank you, Ashrafi Appa again, Ms. Fatima Appa again, and I get to Fauzia Appa for her comments, please. Thank you, Fauzia Appa.
Unmute karo, Fauzia, unmute karo.
Thank you, Rehana, for your breathtaking presentation, which was very in-depth. And Siva, your presentation was also very nice. So I'm not going to go into that. Just want to focus on what we are actually doing in Bangladesh. So to tell you frankly, in Bangladesh, we follow the list, as most surgeons do, from our memories. We do not use this prescribed and printed checklist in our practice, to tell you frankly. Maybe Fatima Appa, they tried in their facility. It continued for a few months, but due to lack of teamwork or enthusiasm, it was stopped, perhaps. Now, considering the safety issues and regarding the briefing and debriefing, I also do it, but not as in a coordinated or in a constant manner. When I used to work in NHS, it was routine practice, but in Bangladesh, it needs a teamwork. So routinely, it is not practice, which is the actual truth. Now, considering the safety issues in surgery, I think we should implement this on a priority basis. Now, why safe surgery is important? And you see from the incidences of the traumatic injuries and the rise in the cancers and the cardiovascular diseases, the impact of surgical interventions on public health systems will continue to grow. And surgical care has been an essential component of healthcare worldwide for over a century, we all know. And again, in Bangladesh, And surgery, we all know that it can prevent disabilities and reduce the risk of death from the common conditions. Now, the millions of people undergo surgical treatment all over the world, and they account for the 13% of the world's total disability adjusted life years. And it is intended to save lives, we all know, but unsafe surgical care can cause substantial harm. As Rehana has rightly mentioned in her presentation, that the mortality rate after major surgery may vary from 0.5 to 5%, and the complications after inpatient operations occur up to 25% of patients. And in the industrialized countries, in fact, half of the adverse events in the hospitalized patients are related to surgical care, and half of the cases in which surgery occurred led to harm are considered to be preventable. And mortality from general anesthesia alone is reported to be as high as 1 in 150 in some parts of the sub-Saharan Africa. And in our part of the world, we don't have any statistics, which is the real truth. And therefore, the working groups reached consensus on the 4 areas in which improvements could be made in the safety of surgical care, like the surgical site infection prevention, safe anesthesia, safe surgical teams, and the measurement of the surgical services. Now, in fact, a systematic review and meta-analysis, which was published in June 2021, and the study was registered in Prospero. It was, they screened 1,562 citations and included 47 papers. The study was on the implementation strategies and the uptake of the WHO surgical safety checklist in low and middle income countries. And it concluded that the surgical scale checklist improved the clinical outcomes in the lower and middle income countries. And as Rehanna has rightly mentioned, that the surgical safety checklist has 3 components, which the first part is done by the nurse and the anesthesiologist, the before induction of anesthesia. Second part is done by all 3, the previous 2 and the surgeon, before the skin incision. And the third part is completed before the patient leaves the OT, it is completed. We all know that major surgery includes any procedure which is conducted in the operating room, and it involves the incision, excision, manipulation, and suturing of tissue, which usually requires regional or general anesthesia or profound sedation to control pain. And the 5 facts about surgical safety, we have Rehanna has already mentioned, and I've also previously mentioned. And the known principles of surgical safety are inconsistently applied, even in the most sophisticated settings. So it is not a very clean-cut procedure or process we have to go through. And again, to remind that the 10 essential objectives of safe surgery are that the team will operate on the correct patient and at the correct site. And they will use methods which may prevent the harm from anesthetic administration and while protecting the patient from pain. And the team will recognize and prepare for the life-threatening loss of airway or respiratory function. They can recognize or prepare themselves for the risk of high blood loss. They will avoid inducing any allergic or anaphylactic reaction. And the team will consistently use methods which will minimize the risk of surgical site infection, like giving antibiotics 1 hour prior to the procedure. The team will prevent the retention of instruments, sponges in the surgical site. The team will secure and identify the surgical specimens, effective communication and information of the critical patient, and safe conduction of the operation. And they should establish routine surveillance of surgical capacity for human results. Now, how to guide for the surgical checklist? Like, we have to include the colleagues from other clinical disciplines, like anesthesia, nursing, these discussions, and identify. Can you mute yourselves? Someone, or you can hear your conversation. And we have to identify a core group of people who are enthusiastic about the checklist, while trying to involve at least 1 member from each of the clinical disciplines. Like, enthusiasm and those who really want to work on it should be, they should be recruited. So at this early stage of work, and those who are really interested.
Sorry, you can mute, Appa. You can mute.
Mute হয়ে গেছো, unmute করো।
Okay. No, I didn't do it. It was automatically done. Okay. Can you hear me? Can you hear me? Okay. All right. And then again, we have to meet with the hospital leads, the administration. So, and the WHO kit, which is in the online, which is available online, they have PowerPoint presentations, which can be modified and used to present the checklist to our hospital leadership. Like, I'm leading the gynecological oncology. So we need, we have to prioritize the patient with the comorbidities where they are having heparin or Clexane. And like all this, we have to checklist that the frozen section histopathology department is priorly contracted, because operatively we send the specimen for frozen section biopsy. So these things has to be included. So we can actually modify the checklist. And we have to make the leaders of our hospitals understand that the benefits of the lower complication rates and the potential for the cost savings in the long run. And we have to start small. Like we can start in one unit, one department, and then if it works, then we include the others. Like we start small and then expand. And we have to test out the checklist in one operating room and then one team moving forward. And then those who are enthusiastic, we can include them. But we should not hesitate to customize the checklist according to our setting, but we should not remove safety steps just because we are unable to accomplish them. That should not be compromised. We have to collect information, the baseline data. We have to fill up the question for hospitals to answer prior to implementing the checklist. It is also available in the WHO website. It is a 4-page interactive document, and it should be shown to our leaders, and they can change it or modify it. And then we can assess the areas of potential improvement and run a multimedia campaign. And the next step should be to make the larger hospital community aware of the importance of the checklist and to get medical professionals using it. And we can include the patients and asking them that whether they want to be included in this checklist or not. So we don't have to wait until the multimedia campaign, but we can start in our own operating room. We have to continue data collection, set public goals, update the hospitals on progress. And we have to write in a schedule for updating the hospital, like every month or every 2 months or every 2 weeks. That will depend. And again, we repeat the same procedure. Continue to collect data, set goals, publicly announce our successes with regard to the checklist uptake and specific items, and the overall surgical complication rates, and continue to meet the hospital's leadership to think about ways to improve the checklist. And the challenges, we take feedbacks from different levels about the challenges related to the checklist, and we have to share our findings. Otherwise, it will not continue or progress. So the essential steps, I think we should, if we start as a pilot, like in Shoaib Sarwardey Medical College that Fatima Ashraf Appa did. So the implementation plan outlines the steps our team should take to accomplish the shared goal or objective. So if we want to develop an implementation plan, we have to define our goals, conduct a research, map out the risks, and schedule the milestones, assign the tasks, and allocate resources. And again, to implement the plan of the checklist, we can make it easier for our team to measure the problems and performances. We can broadly define our goals, the deadlines, and project outcomes, the task due dates, like the timeline, I mean, the risk assessment, team member roles, and the responsibilities, who's going to lead, who are going to be the associates. So the work plan template consists of our objectives, proposed activities, timeline, persons implementing activity, risks and mitigation, the notes, the stakeholder mapping, activity planner. Like Rehanna told me how if you want to implement in Bangladesh, if in my hospital, I can start with my unit and then include other surgical departments, and then OBGYN and all the surgical departments, we can do it. But if I want to implement in Bangladesh as a whole, then we have to make a work plan template with we have to submit a project proposal with a timeline, the implementing activities, the risk mitigation, stakeholder mapping, activity planner. And then we can do some story gathering, the case studies we can actually share in the awareness programs or in the media. Yes. And we have to emphasize on the data protection, informed consent. Then awareness program.
Thank you, Fawzia Appa.
Yeah.
Thank you for your.
So I think that was all monitoring, evaluation, surveillance, and research. That is all for implementation, I would say.
Okay, thank you, Appa. Thank you, Fawzia Appa. Thank you very much for your details input. I like to go to Sharmin Abbasi. She's always in my right hand, but today she has been busy. I can see her, and I just request her to ask the questions on behalf of, there is some other questions there as well in the chat box. Sharmin, are you there?
Yes, Appa, thank you very much. Thank you, Rehanna Appa, for your fantastic presentation, and also Siva. Actually, PHA is our platform where we can get exchange between Bangladesh and other OBGYN specialists all over the country. So we can also measure the standard, and we can also take the decision how much implementation we should do or how much hard work we should do. From the safety measurement of the surgical aspect, we perfectly get idea from our scenario and our situation from our dear Fauzia Hossain madam and Fatima Ashraf madam. They perfectly said. But my question to Siva that in Bangladesh, we need to do many obstetrical emergency in different setup. So when our mid-level doctor or any junior doctor is doing the obstetrical emergency cases in any setup, what is the minimum logistic or safety ensurement they should keep in mind when they are dealing this sort of case? Because all time we never get the access to the tertiary medical college hospital or very high level hospital. We need to do this sort of cases very minimum logistic support leveled hospital. So what is your opinion, Siva, please?
Thank you. Is it regarding an anesthetic safety?
As a whole surgical safety, because it all tell about it is a teamwork from the anesthesia, from the nurses or technical point of view, and also from the obstetrician or surgeon's point of view. So what is the minimum criteria that we should ensure?
Right. Okay. So from in a smaller DGS setup, not a tertiary center where you got really good infrastructure. Okay. So hopefully most of the times we have filtered the patients so they can go to tertiary hospital, but it may not happen all the time. So you may be in a situation where you have to deal with a complex obstetric patient in an emergent situation. What we need to do is we need to make a plan beforehand, both with obstetricians, midwife, and an anesthetist, and make an overall plan about the type of anesthesia, how much surgery you're going to do, if there is any support you need intraoperative from other specialties such as pediatricians or physicians or any general surgeons. And if you're expecting blood loss, if you're expecting cardiovascular problem, am I getting it correct? Did I get your question right?
Yes.
So it may not be always possible. The lucky in the obstetric group is very lucky because they're usually healthy population. As long as we don't do anything really stupid, and if the patient is unlucky, most of them withstand their anesthetic insult, surgical insult, or even blood loss. I've seen the lowest hemoglobin in a pregnant lady of 2, and the patient got discharged after a week. They do withstand the insult very well. Unless it's a category, a crash section, you always have a time to have a quick catch up. Where things go wrong, things go unexpected, right? The patient's, pushed into theater, no one knows what's going to happen. But if you just have a 5 minutes quick chat with the surgeon, anesthetist, and midwife, we just tell them what is expected, what can actually go wrong. So everyone is prepared, so they're not in a panic, so they can actually work in a very planned way. It could be any kind of emergencies. That quick 5 minutes briefing is very important. It's absolutely possible, even in emergent situation. We have seen it and we have done it. So I think the communication within the team is the key about the patient safety. We have seen it many, many times. A bad teamwork is unsafe.
Exactly.
Lack of communication
Okay,
between the team is unsafe.
Thank you, Siva. I just like to add, because I also, I trained in Bangladesh and then I moved here. I understand where Sharmin coming from. So what we started, even in England, even if it is like, say, emergency situation, what we're trying to do, everyone thinks that, okay, we can't spare 5 minutes. That's not the truth. So instead of taking her to theater and then like not knowing what we are going to do, we should learn to spend, even if it is 5 minutes, everyone needs to be gathered together. Say I am on call and then someone got like this fetal bradycardia, we're moving her to theater and maybe she'll end up having a general anesthesia. Even then, what we do when we are actually moving the patient, we take at least 5 minutes now, try to get together, say that what exactly we're going to do. So the anesthetist will ask me, okay, Rehana, what do you want to do? I'm going to say, yes. They will say, do you think I got time for spinal? I will say, yes or no, depend on the CTG and depends on the situation, depends on the mom's coexisting morbidities. Then,
Yes.
so quick chat like that. Then we decide about the anesthesia. Then we also call the neonatal team that please come because this baby may need your help. And so we are lucky in NHS or England and like, you know, income countries, we have got all these facilities. Now, if I go back to my, when I was a student,
Just add one thing, recent incidents, just I want to share and needs your opinion. If you are doing any surgery and at the same time, if the patient undergo any cardiac arrest, so what is the role of the obstetrician at that moment? Is there any role of the obstetrician? Obstetrician is doing the surgery, just complete the surgery or any other role from the obstetrician point of view?
no,
Or who will this cardiac arrest patient in your
okay,
setup?
I went through this similar situation. We had patient which like she came post-operatively, like after delivery, then she had aneurysm and burst, but she was like a postnatal period. So we obstetrician was involved because initially we didn't know what's happening. And then while opened her up, laparotomy, she had cardiac arrest. You that time actually guided by the anesthetic colleague, you actually tell them, so that time, the anesthetist will tell you as much as you can, stop the bleeding, do that. Even if you have, and try to get the fluid up, try to bring the bloods if you can. So we actually work as a team. So I get guided by the anesthetist to tell me what we should do. But other thing we do is that as a team, we actually learn the basic life support. So you need to continue. I have worked in a situation, we actually doing the CPR at the, like by rotation, someone is doing the chest compression, someone is doing the airway. So this is the situation, you have to work as a team. There is no other way. And anesthetist saves lives that time. We just get by the anesthetic team.
Yes.
Actually,
And
the
I-
recent incident that took place, that was very unfortunate. The anesthesiologist did his best, the obstetrician did her best, but unfortunately we lost the mother. So it was bad.
Yeah, I think I read a little bit about it. I think we need another whole session to
Another
discuss
session
about
for
that case. But what I like to say, I think there is another question. What do you do if someone having eclampsia? What are you going to do? How are you going to, if there is a first thing, any eclampsia is actually, first thing priority is that you actually stabilize the mom.
Stabilize the
So
mother, yes.
As
decrease the blood pressure.
first is the mom. And then once you stabilize, I have seen that this mistake happened even here, that someone is having fit and the junior registrar is pushing the patient to the theater to have a cesarean. No, that's not, just you don't do. That time you actually stabilize the Caesar. So give the Maxalf, put her in the left lateral, do the ABCD, airway, breathing, circulation. You support the mom first. When the mom is stabilized, then you
Then
actually
we
consider the
assess.
baby. And then you go and deliver the baby whichever way. So always moms comes as a priority to first stabilize one person and then do. Now, if as a part of resuscitation, say maternal collapse and the pregnant lady, then you may have to do perimortem cesarean only to as it is part of the resuscitation, and maybe by the time you get enough time to save the baby. But that time perimortem cesarean is not to save the baby, is actually save the mom, because that's part of the resuscitation.
Exactly. Appa, I have another question because here is the Kohinoor Madam. Kohinoor Madam is one of the leading person of the BCPS, and with Madam Fatima Ashraf Madam also struggling in BCPS with implementation of surgical skill and others. And our one of past president, Samina Chaudhry Madam also here. There is a one big thing is coming regarding the safety and the surgical safety, that quality assurance, because many of we fellow or the young fellow took the training from BCPS or OGSB or Surgical Society, and they start to do work. But when we start work, there is a minimum assurance of the quality assurance from the obstetrician or surgeon's point of view. So, Madam, my question is from BCPS or from OGSB, is there any setup to see my surgery is perfect or my surgery is maintaining the quality assurance of safety of the patient? So I think Kohinoor Madam, Samina Madam and Fatima Ashraf Madam can add here shortly, and then Rehan Appa can guide us what we should actually do.
Thank you, Sharmin.
Siva wanted to add something. Siva, do you want to say something? Then we'll come to Kohinoor Madam. Thank you, Madam. Siva, do you want to add something?
No, I've got a few things, but I'll just wait for them to finish this. That's all. I'm
No
happy
problem.
to.
Thank you, Kohinoor Madam. Thank you.
No, when the Sharmin questions, what I think that the training, when they took the training in the institute, where they complete the training, these things should be taught in the institute. It is not the responsibility of BCPS or OGSB to teach them at this moment, because when they take the training they are to complete their FCPS or some postgraduate degrees, when they give the training, then they should learn it from the institute where they get the training. And unfortunately, like Fatima, I have to say, in my institute, I am now working in a private institute. I have already made a laminated surgical safety checklist and obstetrician cesarean section checklist in my OT, but unfortunately nobody follow it. So we have to make the junior physicians or doctors to follow this surgical checklist, or to how to resuscitate the patient. Then the Sharmin Abbasi, it will be easy for them to teach them in this either BSMMO or in BCPS. Otherwise, it is not basic thing should be taught from the institute when you are taking the training. And it is the responsibility, our responsibility, to make this training to train how to resuscitate the patient of PIH or APH or PPH, so that they can practically apply it when they will go for their post-graduation and what they will individually treat the patient. Sharmin.
Thank you, madam. Thank you. Samina Madam, do you want to add here anything?
Yes. Actually, both the presentations are very excellent. And one thing I want to highlight, and you also said that we need a culture of using this checklist. And for this, I think one thing we can do in our OT and also in labor room, we should have a poster on it so that every day we can see, and that will be very much helpful. And another one is we have to teach all the physician or it is for common people also, the basic life support. And Dr. Tasvirul said that once he talked to me and said that we want to implement it in Bangladesh, and he want to make some planning on this issue that for basic life support, at least the initial support, how we can teach all the people, because at any place, at any time, there is maybe it is needed, and which is very important in emergency situation. So I think we need to implement it. And if we could start it, though we have got something, but still we need the use of this WHO checklist. And if it is better to use for it in developing countries, because not only in BSMMU, Dr. Fauziya said what they are doing, but it is not implemented in our rural areas or Thana Health Complex. So we have to think the situation in there, and we should make a checklist for them also. At least that is minimal that is needed. That Sharmin said that in emergency situation, what we can do for this, for the safety of the patient. These are the things we have to simulation training should be needed for us. So I think that if we start it, we can do it. That already BCPS is doing it. Thank you.
Thank you, madam. Ashraf Appa, are you going to, Fatima Appa, are you going to add anything, or Jinat Appa? Jinat Appa, are you still there?
Yeah. I want to add something. Is it possible?
Possible,
You have to unmute her. Thank you very much. Thank you, Dr. Rehanna. And assalamu alaikum to all. And I have to say both the presentations were very, very, wonderful, and they really illuminated us. All we know this surgical checklist, but actually we are not following. That is true, we have to admit. Anyway, actually it depends upon the motivation of a surgeon, anesthetist, and the nurse supervisor of the OT. But in that place, our nursing supervisor are very much, I'm sorry to say, they're not that enthusiastic. Rather, they're very much reluctant, and they depend upon the surgeon or, anesthetist. So the second thing is anesthetist. He is the one, he is starting and he is finishing. Because sometimes surgeon enters late, because juniors, they start opening the abdomen or something like that. So anyway, it is a teamwork. Everybody has to follow the rules, and it is not very difficult to implement. Just we don't have that much motivation. But if we want, we can start it. Second thing, I just want to answer for Dr. Sharmeen that in Bangladesh, since 2005, regularly twice in a year, we are providing training on adult resuscitation, basic adult life-saving resuscitation skill, and also the resuscitation of the shock of a pregnant woman. And that is going on since 2005. Kohinoor Madam is here, and regularly we're providing that. And I am happy to say that a lot of our postgraduate trainees, students, doctors, they are quite aware of this procedure, and they are doing and they're practicing. That is the good thing of our part. And lastly, what I want to say here, yes, we need to be very careful about this training program, what Kohinoor Madam said, that BCPS or OGSB, they are not in a position to train the trainee. The trainee has to take the training from their institute, because they are supposed to get 4 years training. So the trainer of that particular institute should guide them whether they're doing the right thing or wrong thing, whether they're maintaining the surgical skill perfectly or not. So that is totally to the teachers, to the trainer. So hope we will be very careful since now, because it is evidence-based, that if we follow the surgical checklist, the mortality and morbidity is very less. Thank you so much for the brilliant webinar and discussion. Thank you very much.
Thank you, Jinat Appa. Siva, do you want to, what you wanted to say, Siva, can you add?
Yeah, sure. Just with the discussions we had, I've got a few things that I won't take long. Cardiac arrest during intraoperative period, whether it's obstetric or gynecologist, who does what? And yes, anesthetist leads the cardiac arrest. However, the team has a significant role in saving the patient. As you said, basic life support. The cardiac compression, if you do after 2 minutes, you'll get tired. The quality of cardiac compression goes down. So what we do, don't matter, starting from the nurses, surgeons, even the operating theater assistant, everyone has it in cycle. So everyone has a part, and that can be assessed depending on the number of people in the team and their skill mix. And the simulation was mentioned, which is fantastic. Regular simulation of acutely deteriorating obstetric patient, it keeps you refreshed with your skill. And Rehanna knows we do that. A couple of type of courses in our hospital, managing intraoperative cardiac arrest, seizures, eclampsia, all those things can be learned or refreshed through simulation. That's very useful, and it's proven to be beneficial. About the WHO checklist customization, yes, WHO advises you to customize as simple as possible to your setup, so you can actually follow it, not to make it so cumbersome. Keep it simple so people are interested to do it. In our hospital, we have two checklists. One is for all the other surgeries. When it comes to obstetrics, there is a slight variation. So we have customized ourselves. And WHO approves that. And there's a question in the chat box about who leads the WHO checklist. Doesn't matter. Whoever has got the whole grip of the situation can lead. The easiest part is the senior nurse leads it because they are in theater. They know what instruments need to open, all those things. For comfort, it's always useful for the theater senior nurse to lead it, but we can all give input. That's what we practice. But if the anesthetists are comfortable, if the surgeon's comfortable, anyone can lead it. Implementation, is it challenging? Of course, it's challenging. When we started in 2009, it was challenging. I did an audit on adherence of WHO checklist in 2016. We were not even 60% in a hospital in UK. And then when we went back and back, now we have just reached over 85%. So it is challenging. Still, there are surgeons not engaging, anesthetists not engaging. Some of the team members are engaging. You're always going to face these challenges. The best way to start is we surgeons and anesthetists have a good relationship. Not always. Some have a relationship. I think it's better to start with a good team where you have a nice working team. Start in a small, good working team, and then slowly spread it with a wider group. That's the way people will actually see the positive change by implementing the WHO checklist, which encourages others to follow. That's about it. Thank you.
Thank you, Siva. I just want to add something. I think Sharmin asked that once we get trained, how do we keep our competency up? That's one question. Other question was, yes, who is responsible for their training? So when I was a trainee, even under Royal College, we were always told, you as a trainee, it's your responsibility how much you want to learn and how you're going to learn. But we as seniors are here to guide you or support you. So that's one thing. But I understand from Bangladesh perspective, it's not that easy because there's that much of structure like we got in NHS or our COG here or GMC here or BMA here. But what I think we should do, every institute have a guideline of that, say from our institute, it's mandatory that every year, even if not only me as a doctor, even our nurses, even the receptionist, everyone actually does their basic life support training. Every year you have to, it's mandatory. There are so much, and then according to your specialty, there is something is mandatory for us, like say we do prompt training. I'm sure Fauzi Appa knows about prompt training. So in a prompt training, we as the anesthetist, obstetrician, midwife, nurses, even the theater assistants, everyone, even the say ambulance, paramedics, they all comes together. And every year, even though we know how to manage preeclampsia, eclampsia, how to manage shoulder dystocia, how to do PPH, how to do cardiac arrest, how to manage sepsis, but every year it's mandatory that we go and as a team, we get training again. So I think as an institute, say for IPGMR or wherever you people are working, as a lead of that unit, you need to start doing something like that. So then that one thing about how we're going to keep up with our competencies. Number two was that, okay, how do we get trained together? That, as I said, you have to, when you work in the obstetrics, you need the anesthetist to come forward, neonatologist to come forward. You have to build up the team and communicate with each other. Now, when you're going to start implementing the WHO checklist, because as a surgeon, I am responsible for my patient. So if something goes wrong, I will be responsible surgically. So I think as a surgeon, as a gynecologist, we should take the initiative that we all go through the checklist. And we actually, so what I do, even if my, say my registrar wants to go ahead with the surgery, I say, no, we are not going ahead until we do the WHO checklist. Please, can we have the briefing? Can we do the checklist? And then we're going to start the surgery. So I think as a senior, we have to take the lead. We have to encourage. Some of the unit, what they did, even in here in UK, they got in the operating theater or in the anesthetic room, they got wall-mounted WHO checklist, you know, they laminated it. And it's very colorful and very big. No one can avoid it. So you have to pass through it. So you go there and say, listen, this is mandatory. You have to do it. And as I said, even in like a high-income country like UK, in my hospital, it's not that everyone is going to do it. But as a lead, as a clinical lead, I said, listen, I'm going to actually do an audit and see how we're doing it. So I think it will even say, if you are in IPGMR or Salimullah or Dhaka Medical College, if one unit, one professor's unit start it, and then they do an audit in 6 months' time, and then when you will show the result, then others will get motivated as well. They will get motivated. So I think someone needs to start. And as I said, depends on our facility, we can modify it. We can modify it. And it will save us as a surgeon, save our patients, saves our reputation. Because as a surgeon, you don't want anyone to have complication. You don't want, do you? No, we want to save lives. So we take the initiative. That I will say. Thank you.
Thank you,
Any more
Rehanna. So are you
questions?
going to, I don't think there are any questions. So who's going to conclude, you or Siva?
So we don't mind, we both can add something. So what I want to say as a take-home message, that yes, it's not going to be easy, but once we start doing it, we will get used to it. We just have to take the initiative. We just have to take the lead. We have to make it simplified according to our facilities and availability of the things. We have to communicate with each other. And as I said, we were talking that if any units, they want to start implement it, make a checklist, we'll be more than happy to give whatever we know to help you out. And if someone starts it, then in 6 months' time, you can do an audit and we can all see what we have achieved. So that's all I want to say. And thank you for joining. It was a very I learned quite a lot from all of you as well. I learn every day from when we do these discussions. And I will just tell Siva to add something, and we say thank you.
Hi, first of all, thank you so much for all of you for your time and your feedback and your contribution to the discussion. As Rehanna said, it's very useful tool, and it's not going to actually cost money. What it needs is enthusiasm and willingness. And it's not impossible. And is it easy? No, it's not going to be easy, but we will get there once you start. So it's worth starting. And I'm sure you're all very enthusiastic. You can contribute and start wherever you are working. And anything you need from my side or Rehanna's side, we are more than happy to support. Thank you very much, all of you.
Thank you.
Thank you very much.
Thank you very much.
Thank you, everyone.
great
Assalamu
weekend.
alaikum.
Thank you. Assalamu alaikum. Thank you.
Thank you,
Have a good-
Zinatappa. Thank you, Sharmin. Thank you, Fauziappa. Hoping
Most
to see you all in February, inshallah.
Inshallah.
And
Inshallah.
we're going to see you again in August. We're doing 21st of August. You all are invited, okay? Zinatappa is going to be speak about hypertensive disease, and we'll be communicating with you all. Take care. All the best.
Okay,
Alright,
thank
see
you.
Bye-bye.
Assalamu alaikum.
Bye.
Walaikum
Goodbye.